Welcome everyone to today's webinar, What It Takes to Level Up Ambulatory Care. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. Today, we are thrilled to introduce Kemal Erkan, CEO and President of United Medical, and John Donnelly, Director of Business Development at United Medical. Thank you both so much for being here today. I'll now turn the floor over to John to get us started.
Thank you so much, and thank you everybody for joining our presentation on what it takes to level up ambulatory care. Again, my name is John Donnelly. I'm the Director of Business Development here at United Medical. I'm also joined by Kemal Erkan. He's the President and CEO, as well as founder of United Medical. The first few slides, we'll just give a brief introduction to United Medical, as well as go over the learning objectives, and then get into some of the more details of that. So again, the learning objectives for this session is to understand the impacts of cloud technology in the ambulatory setting and learn why integration and interoperability are crucial in ambulatory clinics and surgery centers, as well as discover how independent ambulatory organizers can harness, or ambulatory organizations can harness the clinical and operation efficiencies of larger health systems. Again, so United Medical was founded in 2005 by Kemal Erkan, so we'll have our 19th anniversary soon and our 20th next year. Our healthcare organization is designed to reduce costs and achieve overall wellness by serving 90 different clients throughout the nation with 25 unique specialties. We've been a trusted Cerner, now Oracle Health partner for over 2 decades. And here, our main headquarters is in Delaware. We account for more than 75,000 patients on the primary care level, and over 125,000 patients with within the specialty care. And our mission is to implement a full service integrated clinical and financial solution that positively impacts the efficiency and profitability of the practices that we serve while enhancing the well-being of individual patients and entire populations. So again, United Medical was started as primarily a medical billing company, but it's truly evolved into more of a health network. And most recently, over the last 7 or 8 years, we've focused on our accountable care organization. And that has a lot to do with this presentation and how we really view healthcare today. So again, we're a multi-specialty platform that unites different accountable care programs under one ACO. So accountable care programs really started with Medicare as they were experimenting with different shared savings programs. After Medicare was successful with their MSSP programs, and we've have been in that for 7 years now, I believe, more private insurers, commercial insurers, as well as state Medicaid plans developed their own accountable care organization type programs. We've been participating with several of those. So our focus is on high cost and high risk segments of the broad population. And again, we partner primarily with Oracle Health. Oracle purchased Cerner several years ago and utilize all of their software. So again, this is just a brief overview. Again, we started with the Medicare MSSP, but we have 8 different shared savings programs, and each one of those is unique. And we'll kind of go through some of the challenges of them, as well as the data that's provided in different ways that we manage each of these programs, because each commercial program, as well as Medicaid MCO, really has different objectives, different size patient, different size programs here in Delaware, as well as different upside risk versus shared savings or quality only. So overall, we have about 75,000 patients on the primary care level here in Delaware that we help to manage. So again, our services really fall under 3 buckets. There's the traditional medical billing, revenue cycle management, which would include anything from coding or credentialing denial management, those types of services that we provide for private medical offices here in Delaware and other states. For the improving population health, again, the care coordination, we have care managers, we have pharmacists that we employ. We employ directly some dietitians and social workers, and really our focus is continual training that's focused on not only the software and functionality upgrades, but also really the ever-changing healthcare landscape and what's expected of physician offices. All of this is really rolls up into a seamless transition to accountable care. And really our goal is to provide more efficient quality care for the patients that we manage. So again, these are the 3 learning objectives that the presentation today is focused on. Again, I thank everybody for joining, and we can get into some of the details on cloud technology and ambulatory care. I would say most importantly is to define ambulatory care. And this is really just a wide medical services provided on an outpatient basis. It's a crucial aspect of healthcare and offers a variety of services to patients. It encompasses a broad range of healthcare services such as routine checkups, diagnostic tests like blood tests, x-rays, minor surgical procedures, dental services, emergency services that don't require any type of inpatient stay. It's designed to be accessible and convenient, with convenient locations and flexible hours for patients. And ambulatory care is generally more cost-effective than inpatient care because it eliminates the need for hospital stays and those associated costs. And ambulatory care really emphasizes preventative care management for chronic diseases to help reduce the need for more intensive or costly healthcare services within typically a hospital network. So again, we happen to own a couple ambulatory surgical centers, and may look into partnering with some urgent care centers as well. This next image is really how United Medical sees ambulatory care, and how we take advantage of the efficiencies of our partnerships and the technology available to us. So United Medical's business office is really at the center and provides a platform that allows our clients and providers to focus on patient care. So things like a call center or technology support, functionality upgrades, continuous training, all of this is designed to happen from a central location. So we've really built out a network of providers where we can provide the back-end technology for them so they can focus on providing medical care to their patients. It's something that has really worked well for us, and I hope it's something that your organizations can learn from and hopefully adapt as well. So we believe cloud technology goes hand in hand with the integration and interoperability to allow us to improve patient care, provide efficient and cheaper healthcare, and it allows us to better communicate with our patients. And most importantly, our hope is all of this will one day lead to greater cost transparency in healthcare for healthcare costs, especially related to hospital systems versus ambulatory centers. So the importance of cloud technology includes things like innovation and research, as well as telehealth and remote monitoring. So by definition, cloud technology allows for greater scalability and flexibility, cost efficiency, data accessibility, and interoperability. It offers robust security measures and compliance with healthcare regulations like HIPAA. So regulatory requirements are ever changing, and this allows us to ensure patient data is safe. And cloud-based solutions enable real-time access to patient information from any location, which is crucial for ambulatory care providers needing quick and efficient access to medical records, lab results, and other critical information. So again, typically a lot of healthcare systems were all server-based, which really depended on large IT teams and physical hardware that needed to constantly be upgraded. Those upgrades can be extremely costly and problematic, but moving to the cloud allows you to continually upgrade. It's much more affordable. It's obviously online 24/7. You don't need to worry about things like power outages at a local facility, or needing to worry about backups and all those complex and costly items. cloud technology offers scalability, allowing healthcare providers to expand their IT infrastructure needed without significant capital improvement or investment. So the technology is ever changing. We need the latest available and cannot afford to be left in the past. The flexibility is crucial for ambulatory care practices that may need to scale up quickly in response to increasing patient volumes and new services. Again, this image really shows the improvement of technology over time, and same car brand, same car model, and the technology that has over the years been implemented for base level cars, and how that really results in the software itself being dramatically different over the last 10 or 15 years when electronic medical records were first really introduced during the Obamacare years. Prior to that, they were extremely limited, and during the push in the early 2010s to get more providers, really took off as far as what's available for individual practices. And again, an important part of the cloud technology is just the economy of scale itself. We happen to have several cloud-based systems outside of the EMR, and the economy of scale is huge as far as not needing to purchase additional hardware, being able to just scale up and add different servers online, or purchasing software itself that's available online is very important for not only our business model, but the physician practices that we work with. So this slide is just a kind of a brief description of some things that we've implemented that wouldn't really be possible without both our partnership with Oracle Health as well as the cloud compute that we use. So first, we partnered with Zoom about a year ago, and we were one of the first in the ambulatory sectors that were fully using Zoom for telemedicine that was embedded within PowerChart, our electronic medical record. So all of our telehealth videos or visits today are still done via Zoom, which allows the patient to easily access that technology. It's the same exact functionality as when we're using Zoom for meetings, as well as we can track how many minutes, how many meetings, how many minutes, patient involvement, if the MAs or nurses joined before the visit, during the visit, after the visit. So it allows us to have a lot of feedback regarding the patient's experience. And then even more importantly, we use a product called Artera for our patient communication. And this is really a robust platform that allows us to send, not only obviously appointment reminders, but communicate back and forth with the patient regarding anything from overdue balances to maybe services that are still needed. It could be for patients that haven't come in for a certain period of time that are due for a physical, children that have missed their either their well visits or any of their vaccinations. So then we can use it for that, as well as communicating with patients that may be needing a colonoscopy or mammogram. And the patients can also communicate with our offices via text message, which allows us to cut back on the phone calls. So having these technologies is really important for the practice, because it's very difficult to keep up with, again, the number of phone calls, the amount of paperwork, and all of those ancillary services that take staffing needs and time away from the providers. So supporting telehealth and remote patient monitoring, providing platforms for virtual visits, secure messaging, and continuous health data tracking. These capabilities are essential for delivering care to patients outside the traditional healthcare settings. And cloud technology facilitates better coordination amongst multiple healthcare providers by enabling and sharing of patient information and care plans. This coordination is essential for managing patients with complex conditions and seeing multiple specialists. And Kemal will speak about this as well, as far as our model, having one chart for patients regardless of the practice that they go to. So Oracle Health, formerly Cerner, had built a unique model of one patient, one chart, where doesn't matter if they're seeing our primary care, our cardiologist, endocrinologist, surgeon, pulmonologist. We have 20 or so different specialties. They're all seeing the same chart. So the providers, when the primary care sends them to the cardiologist sees exactly what the primary care has been doing with the patient, and is able to also communicate back to the primary care. Things like updating medication lists and all that is seamless. And we of course know that every health system can't have the same system that we have as far as being on the same platform, but communicating from one doctor's office to another can be challenging, and having the right technology in place makes a world of a difference to be able to not only communicate the patient's needs, but get quick feedback as well, to make sure that the patients are getting the care that they need. And again, this slide is something that we were working towards, even before Oracle Health came to us with the product that they're working on. A lot of the burden in healthcare is, again, the data sources and how much data we're receiving from insurance companies, pharmacies, labs, the state, other government healthcare entities, third parties. We're constantly bombarded with data. And being able to bring in that data, filter that data, sort that data, normalize that data is extremely difficult. It's something that I think every healthcare organization struggles with at times. We have done several unique things within our own databases and applications to try to better sort and filter through that data, to be able to find really what's important, what the patients are missing, what the patients need, which patients are falling into more of a high risk zone before maybe they know it. So we do a lot of tracking of different lab work. Again, medications, maybe they're on duplicative medications, and those can be better off resolved using either different type of medication or different combination of medications. So it's something that we have spent a lot of time and resources over the last several years to really try to filter down and normalize the data that we're receiving to better improve outcomes. And again, without cloud technology, it really does enable the use of advanced data analytics, machine learning, to predict trends, improve clinical decision making. And these capabilities can enhance chronic disease management and preventive care in ambulatory settings. And again, I kind of touched on this a bit a few minutes ago, but our challenges is really data. We get too much data. We have limited resources that both have the technical background to ingest complex data and make sense of it. The formatting and timing is wildly different depending on the specific insurance company, whether that be Medicare, Medicaid, or different commercial payers, how much they want to share, how much is private, how much is what they would consider their IP property. Again, there's not really any across the industry. There's really no standard format for what they should be sharing or what they're allowed to share. So we've always struggled with that, but we have built more recently pretty advanced different portals and databases to help normalize those countless data sources, whether it be different payers or the state, third parties, through remote patient monitoring, labs. We do have a local HIE here in Delaware, or hospital systems. There's countless data that's often duplicative and often difficult to scale down, but we are seeing the light at the end of the tunnel. We believe that we have the right strategies in place, and of course hope to be able to utilize some AI strategies as well to better see the outcomes that the patients need. So again, from a technology standpoint, as far as being able to go through and improve the state of a medical practice, some of our current situations, it could be an unmatched queue, which would come from results from labs or the hospital systems that don't match. Maybe a name was spelled wrong. Maybe it was sent to the wrong provider. Or maybe the result should have been sent on paper. There's medication lists that differ from what doctor's office might have versus what a specialty might have versus what the hospital has versus a claims database might have, and then duplicate charts. And again, these barriers could be the patients themselves giving incorrect information or not sharing all of their information. The barrier could come from technology. Again, it could be too much data or the medical staff themselves. It could be human error. It could be understaffed or staff that's not trained properly. And our kind of goal is to always get to an ideal state where we can normalize the data. We can strip down some of the duplicate data. We can make sure that there's all medication lists, all problem lists are all accurate and up to date to allow our providers to have the information that they need when the patient's in front of them. So a lot of that comes down to, again, the patient having some more responsibilities, the patient being able to fill out forms ahead of time on their phone, on their computer. So the faster we can get the information into the office, the faster we can do chart preps. We can train our nurses and MAs to find data, either again from the patients themselves or from the hospital systems or different online portals that we utilize. Again, everything used to be obviously on paper. We would have to fax things. We'd have to mail items. As that wait time, as healthcare was then digitalized, was supposed to change from that weeks to months to seconds to minutes. I don't think it's changed as quickly as we all would have hoped. I think that digital process has been probably a lot slower than was anticipated when the first meaningful use documentation came out, probably close to 15 years ago. I think the idea was probably everything would be digitalized and more streamlined them as like a financial center or banking situation. Obviously, in the last 15 years, because healthcare is so fragmented, it's been slower. There's been lots of change in direction. I think that we're finally getting there. I think that we're finally starting to be able to get a grasp on where the data is and what the patient needs to have, what the providers need to have. So I do think with different AI tools, with having the patients be on the same platform, with having the patients be able to communicate, see their medical information, our hope is, and what we find is, the more the patients are involved, the better off we are as far as our outcomes.
Thank you, John. So John went over the technical background of these learning objectives. My name is Kemal Erkan. I'm the chairman of United Medical ACO. Thank you for joining us for today's session. One of our goals for today is to share our experience with you, with everyone, what we have done in our settings, in our ambulatory care, and how we can actually maybe help others if they are looking for different ways to see and advance what they do today. So ambulatory care, outpatient practices, these are kind of the terms that we use. What we need to understand is the foundation of the ambulatory care is these are smaller offices, patient-centered, timely care, efficiencies, they're equitable, safe and effective places. So this is every ambulatory care should have at a minimum. So what we were able to do, how we were able to level up or taking this to a next level, is by adding certain elements into this. And these are integration with value-based care, technological advancements, chronic disease management, and the population health management. Now, when we discuss these and when we present these, and those who may, I'm assuming most of the people who are following us right now or who are in the audience, they are in healthcare and they know all these different terms. But the reason, honestly, we had to do this wasn't because we were bored one day and then we need to come up with different things. The reason is because physician compensation model changed in time. And this is happening in the last 10 years, and we feel it more and more in the last couple of years. So the traditional model from fee-for-service to a model that actually is very complex and difficult to understand in many cases, and also at the different office level, if they don't have the right business infrastructure, it would be very difficult to achieve the goals and then keep the compensation level at the same level. So before we were paid for fee-for-service, it's just like the total number of encounters. And today, that's not the case anymore. So it's not just an additional income we are talking about, just retaining our income that we used to make. Now we have to generate value, we have to generate quality, and we have to generate savings in order for us to stay where we were and maybe add more to what we are doing today. Now, one of the issues that I see, I'm going to actually explain this, and then hopefully we can make it. We can make this point very well. So, if we are going to change the entire, if our compensation is changing, if the different elements that we work with, they are not in our control. From the independent physician officer standpoint, what we had to do was, we had to change our behavior. So changing behavior is it's kind of complex in a way that I'm going to actually follow some of these slides in a different way. So changing the health system's behavior. And this was one of the terms, and when you go to my personal website, you'll see this. It will say our goal is to changing the health system's behavior. What that means and how we are able to achieve has a lot to do with today's topic. And I'm going to discuss those and give you guys some examples. So what I understood is what we deal with is smaller offices, independent offices, not at the same financial level. Economy of scale is not at the greatest level. And we were providing as John indicated in the beginning, we were providing medical billing services. Like this is 23 years ago. And then as we realized that we are not going to be in the same place unless we make certain changes, then we got into the clinical part of this equation. So today, I would say 70% of what we do is on the clinical side. It used to be 100% on the medical billing side. So what that means is that we, in the central business office, have to do a lot of different things to support our offices. So meaning, in order to change the health system's behavior, we needed to centralize some of the office responsibilities. And this is important because you can choose to fight with individual offices and physicians and providers, but the best way to do is what can we control, what is in our control that we can actually change. So one of them is take certain responsibilities into the central business office. So then, of course, one of the most important part in not just in healthcare, but maybe in any other industry is the communication and timely communication and regular communication. And then we actually implemented regular meetings with our providers. It used to be on a monthly basis. And after COVID actually changed with the needs and with the format of the meetings, we still have our monthly meetings, but we added initially daily meetings through Zoom. And also we added, we went down to like weekly meetings. Right now, every Thursday, 6 p.m., all of our providers are going through the same meetings. And the other third really important element for changing this behavior is standardizing the training and the workflow. So this is maybe the most difficult, but with the centralized office and having our business development team, our trainers in our central office, and then showing everything in the same way to all the offices, then we are able to actually change every piece a little bit in time. So this is a slow process, but it is a solid process. So today, with our Medicare MSSP, Medicare Share Savings, program year 22, we are number 1 in Delaware, and then number 17 nationwide. And for us being a smaller organization and competing with giant health systems, it is more important for us to be at the best of our game and then just have the best setup. Now, speaking of the best setup is what's going to be most important for us is how clinical integration is in place. And this can be done in several different ways. One of them is, yes, it's just clinically integrated offices. They are just doing the same thing in the same ways. But we, with Cerner's Oracle Health's help, we were able to have one patient, one chart model, where we took that integration to a next level. So this actually provides us anywhere, anytime, anywhere, real-time access for all of our specialists, all independent offices. They are in the same domain, sharing the same chart. So there is no duplication. Now, this is important because you need the best communication with the practices. Now, why also it's important, as we mentioned earlier, we have several different contracts. Right now, 8 to 9 different contracts in this ACO platform that we built. And all these companies on the top, all these insurance companies with the value base, they actually represent something different, and they actually have different metrics. So in order to compete with all these challenges, we needed to have the most efficient. And that most efficient is the logical domain, one patient, one chart model that allowed us to be a little bit ahead of everyone from the beginning. So what you'll see here is from changing the behavior, understanding why that's important is because I needed to be able to have chart reviews, not to be relying on the offices. And then we have this in the central office. And in that, we were able to have review the patient's compliance with their appointments, review their upcoming appointments, how they do after hospitalization, and how quickly we are able to reach out to them, and what screenings we have to do for those hospital discharges. Many of you would know this. We have to reach out to the patient in two business days based on our quality metrics. So relying on the independent offices, individual offices to do that, and tracking that is extremely difficult. So we took that into a different level, and we do that from our central business office with our care coordinators. Now, one of the main, another really important issue for us is how can we actually, earlier I was showing here, how we are changing this approach in a way that are we taking care of the individual diagnoses and symptoms, or are we actually looking at the patient as a whole person? So then we call it as like the whole person approach, 360 approach to better understand what our patients are going through. So maybe until 3-4 years ago, when I say SDOH, no one would understand what I was talking about. I needed to spell it out and then I needed to say social determinant of health, but then I need to elaborate that. But today, when I say SDOH, that's a established, settled term. We know that in order for us to do a better care and deliver a better care, we have to have the SDOH in place. And in order to have the SDOH in place, then we need to have different providers who are supporting us. And you can only do that by increasing the economy of scale. And what we did, we were able to hire social workers. We were able to hire dietitians, nutritionists. And then we were able to hire registered nurses to support the clinical flow, because all this is going to be part of what we do to actually change the outcome. Now, here's what happens. So you may be questioning, you may have a question in your mind, like, what do you mean with these? How do you change the behavior? So one nurse can go through so many different charts on a regular day, but we don't want that nurse to just go through the charts. We want the nurse to communicate the gaps that they find. So this can be in several different ways. It can be patient is missing their follow-ups. They may be missing maybe the different consults that they need to have. And one of the chronic problems that we have is some of the problems, some of the disease are not being managed, like morbid obesity. Many of the primaries wouldn't actually even suggest to have a bariatric surgery or bariatrician or medical weight management consults unless patient complains about that. So one of the change, maybe a good example of the change for you guys is we were able to take this provider group, 180 providers in Delaware, maybe a little bit, maybe 5% up and down. So John usually keeps me honest with the numbers, but if I have these, if we have these 180 providers, and if they were not ordering, or if they were not targeting the morbid obesity as a disease 5 years ago, where they were not engaging the patient and or not having follow-up consults for those patients, today that changed. So none of the patients would leave our offices without all of those issues being addressed, because we would pick up those gaps, those differences in our central office with our nurses. Now, we are not making any decisions unless our providers are on board. Of course, that's an important part. But as we communicate, like imagine if you are getting 15 messages from a nurse on a weekly basis for similar things, at some point what you decide to do from the provider standpoint, start adopting, adopting those changes that we are asking. So now when you see the patient with morbid obesity, now you are actually putting that order for bariatrician or bariatric surgery before we pick that up. That's what we have seen, which helped us a lot in these cases. So from the care model standpoint, what we needed to do is to have, like right now in my office, I was just earlier trying to kind of give you guys some different examples. Like we talk about cloud and the integration and the interoperability. I have like 6 different devices in this office right now, and it's just me, and I'm using all of those. So 20 years ago, there would be only one computer with one monitor. And I have right now 6 different devices, and each of them does different things for me. And it's probably the same for John in his office. Maybe he doesn't have 6, but we probably at least have 4. Meaning that we don't have this device problem anymore. So we don't have to, the computers were so expensive, or the iPads were so expensive. So this is now in a different world. So we are kind of spoiled with all these. So now we have to kind of focus on what can we do with these. So I need to have this real-time access, because when we take these responsibilities to the central business office, I need to have people who can actually remotely access those patients, and it may be in this office, it may be in our Turkey office, but what we do is the same. So we access to the same in real time, same information. Now, one other important thing that's during this process is important, what we implemented, which I actually I tell everyone that they should be taking advantage of this. And does it take time and commitment? Absolutely. But I do, as the chairman of this group, we have 2 clinical teams, and I lead one from the central business office, 1 hour on the ACO and 1 hour on our weight loss programs. I do 2 hours of case reviews, which what that means is our nurses who goes through the chart reviews on a daily basis, entire day, they present to the group. Every nurse presents 6 patients every week. So meaning that they will tell us what their findings are, the missing pieces are, missing diagnoses are, and then they would actually have their communication in place if the appointments were missed and other things. And this is all happening with the technology on the back. So then they would present, and then we would say, well, okay, so maybe you should have done this, or maybe you shouldn't have done this. So I'm just going to give you guys an example, so then it's a little bit easier to follow. What we have seen when we started 3 years ago with the case conference, we had our nurses. They would see patients like someone with an A1C 9.6. Well, we look at their lab work before, and we look at their lab work after we review the patient. But if primary care hasn't changed anything on that patient, and the patient is still with 9.6 A1C, and then they didn't engage the endocrinologist, we actually put that order for the PCP, and then they either approve it or deny it, but 99% they approve it, is because that patient needs the next level help. So that also helps our outcome, because I need to make sure that our specialists are fully integrated in our system, because we don't want this patient to go to the hospital because their A1C is not managed. Same way, if the blood pressure is like 170 over 95, and that's going on for the last 6-7 months, and we had visits, and then PCP didn't change their approach, then we suggest the cardiologist. So because we don't want that patient to end up in the hospital. But all this happens with the good foundation of the system that we have through Oracle Health with PowerChart and our other modules that we use. So I'm kind of processing if I'm missing anything. Now, what we expect from our providers is for them to just participate in our meetings, and then understand the meetings, and then compliance with the ACO practice guidelines. And then what we provide for them in return is in 2 different clinical teams, in the clinical integration, care coordinators, workflow managers, technical specialists in each team, care managers, these are our registered nurses, registered dietitians. Like today, we have 5 full-time dietitians on board. 6 years ago, I had 0. So that's kind of like what you see, how the changes, because now we started with 1 dietitian, we went up to 2, 3, and we are busy with 5 dietitians from the same number of patients that we've been managing in the last 6 years. From the central business office, again, in return for our providers, they receive the discharge follow-ups, appointment scheduling, and annual wellness visits, patient engagements. This is the other thing. Patients are part of the equation, and their behavior needed to change, and that's what we were able to do by communicating with them, not just with 1 visit with the visit summary, but we sent several different emails and text messages, as John mentioned earlier. And these messages, not just like, okay, you missed your next appointment, but here's what the risk of you not taking care of your A1C or your medication. And then you may be at high risk for a heart attack because your A1C is 10 and you are like 50% higher at risk than someone else with A1C 7. So all these are being communicated, including screening. So we are providing that from the central office. And one of the really important part is the reporting, our MIPS and the other reporting with the insurance companies. John, I don't know if you want to mention that little bit, elaborate that little bit, but that actually is being done seamlessly with our system in place. Now, again, the reason we are mentioning this is because all of these things being done in the 3 physician offices. I mean, you guys would know this, a lot of physician offices, there's a wife and husband team. Well, there may be in some cases only 2 physicians. How are they going to do all these requirements? We take care of that with the help from the Oracle Health. So that's pretty much what we have in a nutshell. So the just to leave you a little bit complex diagram. So at any given day, this is what you see here from the EMR, from the PM systems, the pharmacy, labs, and hospitals, this communication is nonstop 24/7. Now, we were able to excel our office operation hours by adding our Turkey office because they are 7 hours ahead. So we are probably covering a lot more than anyone else. That actually helps for us to be staying up to date with everything that's happening with the patients. So the bottom line is the behavior needed to change. We needed the technology. We need to understand what this technology is consists of, like the cloud and the integration between different systems, and also having an operational structure that allows central office to take care of all these extra tasks in the central business office. And that's why I believe we were able to achieve good outcome from our ACO contracts, other than Medicare, from our commercial and from our Medicaid value-based agreements. So in many of those, we are the top performer in the state of Delaware. And that wouldn't happen unless we have a good infrastructure on the IT side. So John, I don't know if we missed anything. So we are now open for questions.
Awesome. Thank you for an excellent presentation. We will now begin today's question and answer session. You can submit any questions you have by typing them into the Q&A chat box on your webinar console. Let's get started with the first question. Has analytics played a role in improving patient outcomes at your organization? If so, can you share any best practices for leveraging data effectively?
Sure, I can certainly answer that. Yes, I mean, the analytics have been extremely important to us over the last decade or so as we've gotten into some of these shared savings agreements. Everything from where our patients are being sent, the cost of those services, what services may have been prevented, as well as different quality metrics and different things. Because again, there's obviously each insurance company is always coming back to us with different gap lists of patients that are needing services, of patients that may have been hospitalized that was preventable, or they were readmitted for the same incident. And of course, a lot of the blame for those goes back to the provider themselves. So we do some of it through Oracle, but we also do have a database that we've created and built and maintained over the years. And that database is certainly helpful for us to sort through the patients and sort through the different programs to try to, get the easy ones out of the way, and then see from a global perspective of where the patients are missing services, and which patients have low risk scores but high costs, or risk scores that may have been missed, diagnoses that may have been missed that could impact the risk scores, because you can't always keep patients either out of the hospital, or you can't obviously keep all patients from getting sick. Those things happen, but you can have an impact on the risk score to make sure that that you're getting credit for the services that were provided. So without the database that we have and the data analytics programs that we have, we certainly wouldn't be able to do that today.
And one of the examples for that would be like just a simple example with the A1C, measuring and monitoring the A1Cs, whether or not they get any care from the specialist or the nutritionist. So we are able to do that from the data analytics to understand that these are the patients who are missing certain things already. So then we can be more preventive by engaging and putting those patients in front of the others, so that they can actually they can be sent to the specialist, because it's the time the care is going to be the issue for those, and that data is helping us to identify them. If someone's A1C is the last 6 to 9 months didn't change, didn't go down, is not controlled, and we have to act, and that's with the data analytics. That's the help of the data analytics.
Great, thank you both. Our next question asks, can you talk about cyber risk security for the cloud-based information?
Yep, of course. I mean, we have a lot of it comes down to training. So we provide a lot of HIPAA and cybersecurity training to every employee that enters our organization, as well as anybody that needs access to our system, because we want to make sure we of course can't prevent something that would happen to Change Health earlier in this year. There will be cyber attacks on the larger institutions, but we can do our best to make sure that our employees are trained, that they have the knowledge for what's acceptable to do while they're at work. We do some monitoring. We do some, obviously we have multi-factor authentication enabled for almost every application that we touch. We do annual HIPAA or cyber risk assessments that are easy to find online, different kind of check sheets that you can go through. So for a smaller practice, it's easy to go through the checklist to make sure that you have appropriate firewalls set up on your network, to make sure that nobody has access to your network that shouldn't, and to make sure that you have BAAs in place with every vendor that you come in contact with. So protecting yourself from those small incidents is certainly something that's doable for a practice at any size. And then for the larger aspects, we rely on Oracle and their systems to prevent any larger scale attacks.
Great, thank you. How do you anticipate cloud technology further impacting your organization in the future?
I think for a long time, again, before Oracle purchased Cerner, Cerner was trying to build a lot of the functionality themselves into the EMR. And then there was a pivot, a lot of the FHIR technology and APIs that started to roll out over the last 5, 6, 7 years. And there was really a pivot away from the software vendors themselves building a lot of that functionality platforms, and that is really pivoted towards third parties. So let the people that are great at remote patient monitoring build a remote patient monitoring system, and then through some of the, again, we used to always just have HL7 interfaces, and it was pretty limited for what we could send and receive. But now, again, with different API connections and the FHIR platform, we can get information from hundreds of different companies that can specialize in patients filling out forms, again, patient communication, patients entering nutrition, diet, medications, patient being able to see their medical records and being able to contribute to their medical records. So, we do think that it's, the EMR, the electronic medical record vendors are more developing and should be developing more of an app store experience where they can certainly approve and monitor different connections. But, we're hoping that a lot more technology can be built upon the EMR from third parties. Again, we use Zoom and those types of things, having Zoom fully integrated within our power chart. So, the providers can just launch it from their schedule is something that was, better than a native video platform that any of the EMR vendors would have been able to develop.
Awesome, thanks. How did you decide on your EHR vendor and tech partnerships? What did you prioritize for your organization?
Sure, and I'm sure Kemal can speak to this as well, since he's been partnered with Cerner now Oracle Health for 24 years.
2000.
Yeah. When
so that's something, I guess, John, like that decision was already kind of made for us when I got into it. But I think maybe if I can alter that question a little bit, what kept us with Oracle Health is maybe I can actually answer it, because we exclusively use Oracle Health for the last 24, 25 years. And there were times where we could actually either start using another system for one of our practices. We also have a surgery center. We could have done those. The thing is, most EHR companies or the products, they're similar these days. I mean, I don't want our Oracle people to yell at me, but I mean, there's not much different from one system to the other. In the top 5 vendors, it's just your preference, like how you use what you get used to. So, but the difference, I guess, the reason we stay with Oracle is this support and the enhancements that we have on a regular basis, and we are part of that. So right now we are part of like several different either pilot study or the beta testing. And when we are engaged, we don't feel like we are working with a vendor, but more like we are part of that organization. So that's why we stay with Oracle Health.
Correct. Yeah, they've certainly, they've been aligned with our roadmaps have been aligned for a decade plus, and that's been extremely important. And the reason why, again, we've never switched. Things have gotten a lot better in 2024, but there was certainly a time when nobody liked their EMR. It didn't matter which EMR you're using, nobody liked it. So we were able to keep our practices happy. Nobody was. We basically told them that you're going to use Cerner, or you can't be a client of United Medical, and that was an easy sell at the time. And again, I think that where we are today is in a much better place.
Great, thank you both. Our next question asks, what RPM vendor are you using in your model?
The company that we use is Nationwide Cardiology, Cardiodiagnostic. They partnered with one of our cardiology groups, I believe 3 years ago. And then we are utilizing that for our primary care. So then they are channeling the patients through our cardiology practice with this vendor.
Thanks for answering that. And I think that is all we have time for today. I want to thank Kemal and John for an excellent discussion and Oracle for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today. We hope you have a wonderful afternoon.
Thank you. Thank you for joining us.